My name is JoAnna Harper, and I'm a clinical pharmacist, and I specialize in pain management, where I'm going to be representing, or I'm going to be discussing pain management and how to empower yourself without reliance on opioids. And we'll go through some of the political aspects with not so much politics, but just really talking a little bit more about pain management and how that applies here. So the objectives of this session is to acknowledge that pain management is complex. There's a lot that goes into it, but there's also a lot of things that you can do as the patient and information that you can bring back to your providers as well. And we will talk about the car analogy, that pain is like a car with 4 flat tires, and we'll talk about that a little bit more. Understanding the concerns regarding opioid pain medications and why really there's this opioid epidemic. And talking about different options for pain management, so pharmacologic and non-pharmacologic, and then learning different outside of the box type options for pain management. So there's a lot of things that we can do that we have control over as patients. And then I want you to leave here with tools that you want to start developing for your own pain toolkit and learn how to use them and where to go for information. So a little bit about me. This is my daughter through every one of the conferences since she's been born. I am a chronic pain pharmacist in an outpatient setting in Minneapolis right now. And I'm also a consultant pharmacist that creates programs all across the country for pain management, whether that's in facilities or individual offices, so on and so forth. My goal here really is to empower you guys to become active members of your medical team and develop various tools that you can use to help yourself with pain. And ultimately, I'm a scleroderma patient as well. I've had scleroderma for the past 20 years or more. I went through pharmacy school thinking about scleroderma as far as from a patient's perspective, and that's really the education that I have as far as what can I bring back to you guys. So I have nothing to disclose. I don't do any speaking for any type of industry whatsoever. I will be discussing off-label uses of these medications though, because a lot of the medications that we have are not necessarily FDA approved for pain in general. So there's been a lot of patient comments that I hear all of the time, and I'm sure you guys have felt some of these. So some of those being my provider doesn't listen to me, or they don't touch me to determine where my pain is or what the cause of my pain is. And nobody's ever really addressed the reason I have pain. And these are all legitimate reasons. And then why is the opioid epidemic my problem? Which is a big question. I know some people have felt that they feel like their providers think that they're drug seeking because they're trying to find alternative options for pain control, and that may or may not include opioids. But ultimately, I do have patients at the end of my program at least that say, I never knew that I could feel this good taking so little medication. And I think that's what's more important here is using a natural approach, or using a holistic approach, including all the options that we have available. We do get better pain control that way. So, you know, the definition of pain, just being very basic, it's an unpleasant sensory and emotional experience associated with either actual or potential tissue damage. That doesn't necessarily mean that there has to be tissue damage there. It's just the view of having tissue damage is actually the definition of pain. So other causes for pain could be things as simple as nausea, vomiting, and gas, or bloating. And the problem is as we go through years and years of pain, we lose our coping skills and that ability to cope with all of the pain that we have, just because physiologically our bodies are changing. The neurons change to the environment that it's given, and that if that's pain, our body has to adapt to survive. And so that's nothing that we've done wrong as patients. That's more of what, you know, just our body does naturally. There's also a bunch of social concerns, you know, any type of stress, relationship difficulties, all of that plays in. And then anxiety and depression, they all kind of run together. Anxiety and depression and pain, it's a vicious cycle. So how do we get out of that? So the car analogy, my video at the beginning did not work, so I apologize. At the end there is the reference for this, but there is a 2-minute video from the American Chronic Pain Association website that a pain is like a car with 4 flat tires. You can pump up 1 tire with medication, and sure, you can drive around with 3 flat tires. You're probably going to ruin those 3 tires, and you can go, you're just not going to go very well. So the question is, what do you do for those other 3 tires? And the only way that you can live, a full life with pain is you taking an active role and you being the driver of that car. So what are those other 3 tires? So that's the other complementary medicine we're going to talk about. So whether that's physical therapy, occupational therapy, whether that's essential oils, whether that is psychology-based training, mindfulness, meditation. So it's really what 3 tires, what 4 tires are you going to use? Different techniques are you going to use to fill up each tire? So it's as a patient, it's our responsibility to look at, what tools are going to be most beneficial for you. What tools work for other people may not work for you, and that's okay. Believe me, I have a colleague here who could tell you all about it, that I am still struggling with meditation. It's been 20 years, still struggling with it, but you know what? We'll get it eventually. And so, ultimately, you don't take your car in to the mechanic or to the shop to get your gas filled up or your tires filled up most of the time. So really, the question is, how do you maintain your car? And that's really our responsibility as patients. But it really does take a team effort, and that's really what this is all about, is learning different ways on how to, develop those tools, how to live independently and still manage your condition, maximize the participation in your everyday life, minimize discomfort and side effects, and avoid any bad consequences. So some of the misconceptions of pain. So I want to acknowledge this, that pain is not in your head. I know fibromyalgia, that was the conversation for a good 10 years, that it was a woman's disease and it was in your head. I'm here to tell you it is not. There's a lot of research out there that says there are physiological changes based on that, and there are things that we can do for that. You don't have to live with the pain, and pain is not necessarily a natural part of aging. Yes, things break down, but what can we do about that? And you are really the best judge of your pain. It is not your provider, it is not your nurse, it really is the patient. And seeking medical care does not mean that it's a sign of weakness, and using pain medications does not lead to addiction directly. So we'll talk a little bit more about addiction versus tolerance, but most importantly for me in general is talking about the importance of pain treatment. So poorly managed pain can actually cause some physical symptoms. So decreased appetite, a weakened immune system, which we all know is part of the problem sometimes, aggravating other health conditions, depression and anxiety, difficulty concentrating. It can change your social interactions with people, including significant others and spouses and family. Sleep is changed, work productivity changes, as well as a loss of self-esteem and independence. So all of that is incredibly important in your lives, and so treating the pain really needs to be addressed. So one thing that I think is important to note here, were a bunch of studies done on patients who had no pain whatsoever, 0 pain. So I want you to see that in 68% of these patients, no pain, 68% had cartilage damage. Okay, so, and then another for disc degeneration, 80% of these people had disc degeneration. So just because they talk about some of these things doesn't necessarily mean that it's going to lead to pain. And that leads me to the nocebo effect. So the nocebo effect, really our providers don't intend to do this, and this is usually an unintended consequence of just using medical jargon. But part of the concern is the nocebo effect creates a harmful effect by using either therapies that are inactive, but to a patient, those words can feel like they're going to be in pain for the rest of their lives. So degeneration, stenosis, and inflammatory, those words do not mean lifelong pain. It doesn't need to be. And then some of the good sayings that we change it to, instead of degeneration, it's my nerves are in a smaller house. or motion is lotion, or I have fussy joints. So basically what I'm trying to describe here is that our bodies change a little bit every day, both for the good and the bad. So it doesn't mean that just because a joint is, it has degeneration, does not necessarily mean it's going to be lifelong pain. So if we use some of these techniques, we can actually regain some of our ability. So why are opioids so bad? And this, I get this question literally every day, at least 6 times a day from every one of my patients. So the CDC guidelines came out and basically said, we really need to look at pain and look at all options for pain control. Well, yeah, we kind of should have been doing that all along. So there's nothing new there, but what is new is they put a number to the morphine equivalency per day. And I will tell you how they came up with that number was some studies. I can't tell you the validity of said studies, but really that doesn't matter in our world here. Really the goal is using the most effective medication at the lowest effective dose. So 20 years ago, opioids were the answer. That was the answer to everything. It was our magic key. These are great. Okay, 20 years later and millions of people, we now have data to show, okay, maybe they weren't as harmless as we thought they were. So some of the things that happen with this, initially, opioids don't treat pain. They don't treat it at all. They just block your brain sensation of pain. So not only are we not treating it, but the other long-term effects, decrease in immune function. It's just like not treating the pain at all. Depression, weight gain, increased disability. There's 6 vital hormones that your body needs to function. And I have seen patients where those hormones are so low that they are near the brink of death just because of the dose of those opioids. Now, granted, that's really high doses, but these are all concerns that we need to look at. We don't see people improving on large doses of opioids. And ultimately, it decreases our coping skills. If you think about it, before we had opioids and we had this quick answer, what were we doing? Well, we were looking at mindfulness and heat and ice, and we were looking at all these other options that we had. And now that we have this magic pill and it's quick and easy, which believe me, I'm all about quick and easy too, but we lost our coping skills. We lost that ability to empower ourselves to find effective treatments. So that leads us to fear and isolation, increased complications as you get older, and there are so many drug-drug interactions that, I've seen a patient be put on, an antifungal medication for a yeast infection, and she go through opioid overdose and in the hospital. So there are a lot of consequences to this, and really, if the meds aren't working for you and you're not getting more function out of them, they're not the right drug for you. So and a lot of the time, that's the opioids. So there's always the question of dependence and addiction. Physical dependence is normal. That's just the fact that your body is going to go through withdrawals just simply by stopping them suddenly. That's normal physiological response. Tolerance is that need to take more over time. Some people get it, some people don't, but again, that is normal and that is not addiction. Addiction is when there is harm that the doctors have, basically determined that this will cause harm for you, and you decide to continue it anyways. And that's where we start bordering on what should we look at from a psychological approach. And then there's also the pseudo-addiction, which is what a lot of my patients go through right now. And really all that is uncontrolled pain. People are fearful of being in pain. And so they're gonna have some of those same behaviors that look like addiction, but in reality they're not. And so it's how do we present differently to our providers to not make it look like we're drug seeking. The role of the pharmacist really is looking at different medications, different classes in each medication, and we'll go through a lot of those medications, making sure it's the right drug for you individually, looking at drug-drug interactions, looking at drug-disease interactions. So how are your kidneys functioning? How are your liver, how is your liver functioning? Doing a complete medication review, looking at all of the medications you're on and how do they play together. Is there something that we need to change if we add one of them? Because there is an interaction. Looking at any barriers to care, so that's affording medications and being able to take them appropriately. So if you have difficulty swallowing, what other products do we have available? I do have some limited prescribing abilities in my clinic and through collaborative agreements. And then the other thing is that I think is really important to mention is having naloxone at home, which is the rescue medication for an overdose if you are on opioids. And a lot of the pharmacists now can do that, and your providers can surely do that as well. So the medication options. Now, as a pharmacist, I am saying just say no to drugs. And the reason I say that is because everything has a side effect. So really, yes, we can use drugs if we need them. They do have a place, but they should not be the answer. We should not be concentrating on just one wheel. So the medications we're going to talk about are different muscle relaxants, nerve pain medications, antidepressants, things for inflammation, as well as Tylenol and other opioids. So muscle pain, when we talk about muscle pain, there's a big difference between spasticity and spasms. Those are two different beasts altogether. So the spasticity is when it's really stiff and bigger muscles that don't work very well. And then the spasms are kind of the come and go, the jerking, the twitching, the cramping. And so it's really important to differentiate between the two because this slide talks about the difference in medications. So on the left-hand side here, it's the muscle spasticity when it comes to those medications, and then on the other side, it's muscle spasms. So some of the medications for muscle spasticity, baclofen, and I think what's important there to know, I didn't include any type of dosing. I'm bringing in just things that I think are important to you guys without giving you a full pharmacology review on all of these. So baclofen, the biggest things to look out for is dry mouth and sedation, and that you can have withdrawal with that. And then tizanidine, dry mouth again. So these are ones that if you already have Sjogren's, you'll probably want to avoid those. The diazepam or Valium has been used both for spasticity and muscle spasms. It's the only one that's been approved for both. But again, it can have sedation, and it has a drug-drug interaction with opioids. So that is one of the CDC guidelines that I do agree with. As far as, you know, if you have high-dose opioids and you have benzodiazepines like a diazepam or Valium, lorazepam, Xanax, any of those, it decreases your brain's desire to breathe. Nothing you did wrong, it's just drug interaction, and it's your brainstem, and we kind of need that. So other options that are a little bit further down the line are dantrolene, which is another option. And then it looks just like phenytoin or Dilantin, and as far as structure is concerned. And then Botox. Botox is another one that I think is a really important option and can be done in a clinic as well. But you can develop an autoimmune response to that. So that is something that I want you guys to be aware of. For muscle spasms, we have a variety of different options. So cyclobenzaprine, I don't know about you, but most of the dry mouth, that's usually where it comes from. And a lot of people start it not knowing that, and it gets pushed under the rug long term as far as, you know, it goes unnoticed that that is one of those biggest side effects. And it does look similar to a tricyclic antidepressant, and we'll talk about those too, but there can be drug-drug interactions there. And some of the other ones we talk about, metaxalone is one that's obvious, that is often not covered by insurance, and the mechanism really is unknown, and I think that's what's interesting here. So the question is, on some of these muscle spasms, is it just sedation, and that's why you don't feel your muscle spasms, or is it actually doing something? So that's really always my question to my patients is it really doing something? Some of the other ones we see, methocarbamol, that's the one I find is most tolerated by the patients with the least amount of side effects, less sedation than some of the other ones. And then the other ones, the other two, the chlorzoxazone and the orphenadrine, I don't use those as much, but they are possible. But again, the orphenadrine is kind of like a really strong Benadryl. So really, the better options for scleroderma patients when it comes to muscle relaxants is methocarbamol. And my question to all of my patients, they tell me, well, it wasn't effective. Well, what does that mean? Well, did you take one tablet or two? Oh, well, I took one. Well, usually one tablet is just to make sure that you can tolerate it. I didn't mean that the one tablet was going to be the cure-all. That's just to make sure you don't have any major side effects, because I don't want to amplify those side effects with 2 tablets. So a lot of the times, the doses that we're on, we either start too fast, and so we go for that 1,000 milligram dose, and yeah, okay, we have side effects, and then we don't like them. So it's really kind of looking at it from a dose perspective. Was it an effective dose? Was it the right dose? And was it the right timing? And the only drug that I absolutely stay away from, absolutely, is Soma or Carisoprodol. A lot of different ways to say that, but really I call that the holy trinity of death. And the reason I say that is when you add that to benzodiazepines and opioids and Soma, those 3 combined are really where we see most of the deaths from in opioid overdoses. And then metaxalone is kind of that holy trinity of death too. We don't have as much data on that one, but they are making a correlation between that drug as well. So that's part of the reason I stick more with the methocarbamol and the cyclobenzaprine, knowing that there is some dry mouth with the cyclobenzaprine. So when we come to nerve pain and talk about any type of neuropathy, so that's the numbness, tingling sensation that we can get, especially when, in hands and feet. And it's different from the Raynaud's after, you turn blue and come back. It's a little different than that. So we have a few agents that we use for that. So I break these out into different classes of other disease states. So if you have anxiety with nerve pain, we talk about gabapentin being the first line. And the reason we do gabapentin first line is because it's generic, it's cheaper, and I can start at a really incredibly low dose. So I can start at 100 milligrams, but also knowing that usually the treatment dose, honestly, is 2,400 milligrams. So, and I have had patients as high as 4,800. Whether that's the right answer or not, it depends on that patient. So really, really small doses, just to make sure you can tolerate it. And if, you have side effects, we go incredibly slow. Biggest side effect being the dizziness and sedation, especially when you wake up in the morning, kind of that grogginess that's associated with these types of drugs. And then there is a dosage change when it comes to renal dysfunction. The next one that we use is Lyrica or Pregabalin, and that one is FDA approved for fibromyalgia. So I think that that's important to note. Usually it's better tolerated, easier to titrate because there's not as many steps, but also it's still really hard to go really low like I can on the gabapentin. All of these improve sleep, generally speaking, because they do have that sedative quality, so at least I can get beneficial sleep from that. And we'll talk about sleep more in here just a little bit. But the one thing I need you to know about the pregabalin is that it has peripheral edema associated with it. It's a small percentage, but it's a possibility. So if you suddenly have this swelling in your lower extremities, usually that could be associated to that drug if that drug was just newly started. And then all of these can actually be effective for spasticity as well. So I think we try to use medications that have multiple mechanisms or multiple actions so that we can decrease your load on medications. So here's just a reference slide for you. Take it home to your providers. It just goes through changing from gabapentin to pregabalin. You don't have to necessarily start over. So this chart gives you an idea on what the starting doses are based on your dose of gabapentin. So some of the other anticonvulsants that we have, if you're looking at losing weight, we do use Topamax or topiramate, which is also approved for migraines and diabetic peripheral neuropathy. We don't have a lot of data when it comes to fibromyalgia or any other nerve pain, but this is one of the options that we have that's not FDA approved. And then if you have bipolar conditions or seizure history, we'll look at carbamazepine or Tegretol, and then oxcarbazepine, which is very similar, and then Lamictal as well, and Depakote. So that's just to kind of give you an idea that really when it comes to all of these different types of conditions or pains, we have a lot of different options. It's not that we don't, we just don't look at a lot of these on a daily basis. So some of the topical things that I think are really important, if we use the topical type products, we actually decrease the systemic side effects. And we also decrease the drug-drug interactions. And so it's interesting to see how many of my patients get good benefit from a lidocaine patch. And now often, granted, the 5% prescription item is usually not covered. The 4% is much, much cheaper. So basically when the opioid epidemic happened, see the sarcasm there, when the opioid epidemic happened, everybody went to lidocaine patches, and then the lidocaine patch distributor basically said, I'm going to increase the price. And then insurance companies said, yeah, we're not paying that anymore. My patients don't really see a difference. Very few patients see a difference between the 4% and the 5%. And a lot of times those patches can be cut up and placed in different areas. And there's also lidocaine cream, and we do use those for the neuropathic pain. But it is only FDA, the lidocaine patches are only FDA approved for post-herpetic neuralgia. So once you've had shingles, that's when they'll cover that drug, which it's really hard to get a prior authorization through, I guess is really what I'm going there, where I'm going with that. Other options that we have available for pain overall, and we'll talk about individual indications when it comes to fibromyalgia here later in the slides, but a lot of these medications will be in there as well. So there's drugs that work on serotonin and norepinephrine, and those are duloxetine or Cymbalta. That one usually has more norepinephrine effect, which is what we want for pain control, but we also use these for any type of depression or anxiety. So usually we start at a really low dose, like the 20 milligrams if you're really sensitive to medications, with a max dose for pain being 60 milligrams. But what I think is important to mention here is that if you have anxiety and depression with it, we can actually increase that dose even higher, because I believe it's about 10% of the population has a genetic, I can't say a defect, but a different metabolism that they can actually clear this drug really fast. So we'll talk about genetic testing too. But basically, if you're clearing a drug really fast, you don't get any efficacy from the drug if you need that first drug to be effective. Another medication, well, some of the side effects really are increased anxiety initially. So I'm going to let you know, yeah, that can last a couple of weeks to a month. Just know that usually that decreases and ends up treating anxiety. I know it sounds counterproductive, but that's really how these medications work. And then nausea being another big one with that one. I don't see dry mouth as much, but it is possible. Savella is another one that was out there for years that was actually designed for fibromyalgia. And that actually, again, has more norepinephrine activity than serotonin. And they had this really cool kit that you could, it was a 1-pack month titration. To be honest, the demand wasn't there, and so it never went generic. It's still, I believe it is still brand name, and if not, it's really expensive still. So it, again, requires a prior authorization. But if you tried duloxetine already, a lot of times I have wait to be able to prove that you need that particular drug. Usually when duloxetine isn't covered, we'll try venlafaxine or Effexor. So one of the things that's important to know there is you really do need the higher doses to get the norepinephrine activity. So, the first couple of dosage changes are not really going to be as effective for your pain, but we got to stick with it if we can tolerate it to get to the higher doses. And then Prestique looks very similar to venlafaxine, but it's another option with less drug interactions. And then we do still talk about Wellbutrin, mirtazapine, and then trazodone. But the mirtazapine has a lot more of that dry mouth issue, and bupropion has less of the sexual side effects, and it does have weight loss associated with it. So those are all other options if you have those conditions. Oftentimes we do use a lot of these medications in combination. We just watch out for serotonin syndrome or just getting too much of that serotonin. So it is absolutely vital for sleep. Sleep is the most important thing when it comes to pain control. They had done a study at one point of medical residents who had a 72-hour shift where they would, be up and down, basically getting maybe 30 minutes to an hour of sleep. And you know what? After that 72 hours, 80% of them tested positive for what they classified as fibromyalgia at the time. So that tells you how important sleep really is. And if you're not getting adequate sleep and you don't feel rested in the morning, that tells me that's something else we need to address when it comes to pain. So one of the things that we use for sleep is the tricyclic antidepressants. So like amitriptyline or nortriptyline are some of the ones. Usually I go with nortriptyline, to be honest, because it usually has less dry mouth associated with it. But it really does take 4 to 5 weeks to see an effect, and that's once you're at full dose. So sometimes we increase the dose slowly and then see kind of where that effective dose for you is. Again, side effect sedation, which is kind of what we're going for on that one. But it can have drug-drug interactions, and it can have QTC prolongation, which is basically where it takes your heart longer to pump the blood and then refill. But we watch out for all of those. And again, the drug-drug interaction with duloxetine or Cymbalta is something we watch out for. And then trazodone, which was also on the other slide for depression. It may help reduce anxiety as well. And then Benadryl, dry mouth, usually the antihistamines, can't see, can't pee, can't spit, can't poop. Okay, so the other thing is the hypnotics. So everyone talks about, well, why can't I just have Ambien? Or why can't I just have, Sonata? Because those are quick. Again, the quick answer is not always the best answer. And those actually change the structure of your sleep. And so you become dependent on those again, meaning now your body's forgot to sleep too. Oh, so now we have a lot more work to do. So that's why I try to look at mechanism of action like the tricyclic antidepressants or trazodone when it comes to sleep. And again, we talked about the dangers with benzodiazepines and sleep. And yes, when there is a lot of anxiety components that go with it, I do see the importance in that. But there are also non-pharmacologic things like mindfulness and meditation that we can do to help decrease that anxiety as well. So serotonin syndrome, what I alluded to before with the drug-drug interactions, it usually occurs several hours after a new drug has been started or a dose has been increased. The signs include agitation and restlessness, confusion, muscle twitching is another one, heavy sweating, headache is another one that I've seen. And you know what? I have seen this. When you get on higher doses or multiple drugs that all work on serotonin, this is a possible side effect, but that just means that we've hit your maximum capacity for these types of drugs and that we have to look at another drug for you. So really the answer is just going back to the last effective dose that you had. And it can be severe and life-threatening, but usually if you catch it early and you let your provider know, hey, I just started this new drug, can it be related? They can tell you if it's this or not. And so joint pain, we're going to talk about anti-inflammatories. So we talk about COX-1 selective versus COX-2 selective. And so the difference is, basically the goal is decrease prostaglandins, you have less inflammation, you have less pain. That's basically the goal of these medications. And so the COX-1 inhibitors obviously have those GI issues. So increased bleeding, can increase GERD as well. So there's concerns about that. So a lot of times if you need one of these medications, we can often put you on a proton pump inhibitor like omeprazole, but a lot of us are already on those. So some of those products are like indomethacin and naproxen, with ketorolac being the most COX-1 selective, which that is why it works a lot of the time in like the ER or the hospital. They'll usually give you 1 or 2 doses. But it's really, really hard on your kidneys. And it's the highest risk for bleeding. The lowest risk for bleeding is actually the indomethacin when it comes to this scale here. And with the ketorolac, really we limit that to 5 days. I have a lot of patients who really want to continue that long term, and that's just not a safe option for you. And then when we talk about the COX-2 inhibitors, so we talk about like Celebrex or Vioxx that was taken off the market. The big scare with those were, increased risk of heart attacks or cardiovascular events. And they lumped all of the COX-2s together at the time, so Vioxx and Celebrex, they were all kind of lumped together. A new study has just now indicated that Celebrex has just about the same cardiovascular risks as ibuprofen does. So is it none? No, there's still some risk with these medications, but not as much as we once thought, like with Vioxx. And so actually the most COX-2 selective, which I think is really interesting, is Atodolac or Lodine. We don't see that prescribed much anymore, but if my patients tell me that, you know, they get some effect from meloxicam or Mobic, but they don't get quite enough, then we'll try Atodolac to be the most COX-2 selective. So really the difference here for you guys is if ibuprofen works for you and you're not having side effects, but it's not working well enough, stick in that COX-1 category, the ones on the top. Or if Celebrex works for you but not quite well enough, try the COX-2s at the bottom. So it really is patient specific on those, unless you have that cardiovascular risk already or the GI bleeding risk. Other things that I think are important with anti-inflammatory medications, so diclofenac gel. The systemic absorption is minimal, so the side effects are minimal, but my patients get a lot of relief from those. And really all it takes is a prior authorization from your provider to basically say, we do firmly believe that this is the best drug for you. And those are becoming easier to get through now. They do have other anti-inflammatory topical agents, we just don't see them as much. There are a number over the counter. If you do have allergies to these medications, the one in the middle actually goes through the classes of medications. So for example, if you're allergic to diclofenac, you don't want to do, you know, piroxicam or meloxicam. You'll want to do something like indomethacin. You'll want to pick a different class. So each line there is a separate class of medications. And then ibuprofen, if you're allergic to ibuprofen, it doesn't necessarily mean that you're allergic to indomethacin. But it is something, if you do have anaphylaxis, I do want you to know that we will be cautious on all of the above. But anything else as far as, you know, just itching, things like that, we will look at other options. So again, additional concerns when it comes to the anti-inflammatories is, are your kidneys doing well enough? Can it clear that? Because high doses or even low doses, depending on your kidneys, can actually do harm as well. Avoid in the elderly, any type of high blood pressure, those are things that we want to keep an eye on. Swelling and GI bleeding and any history of ulcers. And absolutely, I still recommend taking all of these with food to be on the safe side, and then watching for any signs of bleeding. So this is a chart to take to your providers about when to stop anti-inflammatories. It was a study done by a couple of pharmacists that looked at every mechanism of action, every duration, exactly how the drug works, and it basically goes through every medication for anti-inflammatories and when you should stop. Most of the surgeons will say 5 days, and of course I'm not going to step on any surgeon's toes, but you can bring them to this study as far as, you know, would you mind looking at this and seeing this, if this, you know, is a possibility to where I can stay on that. So ibuprofen, usually it's 1 day, is safe to have surgery the next day. So the elephant in the room, the other options, opioid pain medications. So there's a lot that goes into this. There's new opioid pain medications that are coming out that work on the kappa receptor instead of the mu receptor. The mu receptor is the big bad no-no right now because it can have the psychoactive effects. I will tell you that, you know, there's studies that say the first hour that you take these medications, you get this dump of dopamine, which is kind of the happy chemical. So, you know, even if you're not getting a high, your brain says, this is great. And so then that changes your perception of what pain relief should be like. I'm going to tell you, I want to be like that all the time. It's just not realistic. So we do have other options. And the ones I wanted to talk about in particular are tramadol, which we'll go through as well. Methadone is still a good option with going really slow, making sure that there's no drug-drug interactions and that there's no QTC prolongation. So you usually have to get an EKG done before that. But the importance of methadone is it works on serotonin, norepinephrine, so the same things that duloxetine works on. And norepinephrine is that one that we're really targeting now. But it also works on an NMDA as an antagonist, which basically means there's less tolerance that builds up, and also works on the mu opioid agonist. So you don't have all of that tolerance that builds up. But there are some long-term effects, meaning, this medication can have a half-life sometimes in some people as high as 90 hours. That's kind of a long time for you to clear half that drug. So it's things that we don't take this decision lightly, but it is a possibility in all of the things that we have available. And the thing with opioids, and part of the problem now with the opioid epidemic, is manufacturers are making less. The DEA is sending less to each pharmacy. Each pharmacy only has a certain allotment to give out. And then we're having all these drug recalls. So there's so many different options here playing in. Insurance is now telling me what I can prescribe at this point, as far as, nope, you can only give them 8 tablets a day. So it's kind of turning into, I understand the concern as far as we should have everybody on the lowest effective dose, but I also understand it is patient specific and we have to work with the patients individually. And then there is that fear from the providers about losing their license, or what's going to happen to me if I prescribe this person. So that's usually why they send you to pain management. And then that's where you kind of talk about all these other options. So I guess in that way it is beneficial. The other thing that I think is important to mention here when it comes to opioid pain medications is this really the right option? Are we treating, is this something short term? Can we get you through a short period of time until you develop the other tools? And I will tell you, a lot of the opioid deaths, in all fairness, the new ones that are coming out in the last year, are people getting up from the street. So I will tell you, I understand the desperation as far as when it comes to pain control, but the ones that you can buy not from a pharmacy actually do have like carfentanil in it, which is horse tranquilizer basically, or an elephant tranquilizer. And that's where the overdoses are happening, is we think that the patient thinks that they're taking an oxycodone 10, but in reality, it's really not. It's more like an oxycodone 60, but it looks the same. So those are the considerations I want you to keep an eye on that one. So other analgesics, acetaminophen, I never underestimate the power of Tylenol when used in synergy with some of the other medications. Max dose really is 4 grams a day, so that's 8 of the extra strength, and that includes all of the products you're on. So if you're on a Tylenol bed, Tylenol cold, we need to add all of those up and just make sure it doesn't add up more than the 4 grams or 3 grams if you have any type of liver dysfunction. And then the other thing is tramadol. So tramadol is a weak mu-opioid agonist. So really the biggest effect is serotonin and norepinephrine, kind of like Cymbalta. And so we do lump it as an opioid, but it's like 6,000 times less potent on that receptor than the other mu-opioids. So I think the doctors are now relaxing a little bit more on this one. But with renal dysfunction, we do need to decrease the dose on that one, and then caution with seizure history. So if we do have to, look as far as we've tried everything else and we've looked at everything and know really an opioid is the answer, which is not always the best answer, but that sometimes is the only answer we have, tramadol might be a good option for you. Another good option could be Nucenta, which is a mu-opioid agonist that works on norepinephrine as well. So you get more of that other norepinephrine activity that's important. But also Butrans. Butrans is a patch that you can use that decreases the tolerance that builds up, but is an available option for pain control. So we have a lot of options out there. And all of our providers will require urine drug screens, just minimum requirements that we have to do. So the Butrans patch, just really quick, does not require special licensing, less risk of respiratory depression, less hyperalgesia. So with opioid pain medications, you oftentimes get more pain. And this one decreases that. It may help with depression, which I find helpful in some of the patients. There are a lot of drug-drug interactions. They do have that QTC prolongation, and there is a concern with surgery as far as don't stop it right before surgery. Most providers are not as educated on buprenorphine as they can be. So either stop it a week before or continue it for, throughout the entire surgery, knowing that you're going to need more of an opioid agonist to get pain control in the hospital. So other options, just throwing it all out there, there are ketamine medications that can be compounded, so topical and oral are usually what we use. It can have a hypnotic effect. It is called Special K on the street, so obviously we are going to be cautious on this one, but it's hard to get it out of a cream. So that's why we use creams often, but it can have hallucinations. And then dextromethorphan is another one that they're doing more research on now, which is an over-the-counter cough medication. So by no means am I saying take more cough medication. I'm saying these are more options for you to look into. There's always that question about medical cannabis, and our clinic is very open to this. We have no objection to medical cannabis or CBD oil. The research that's out there, though, a lot of the research is using a product that is much less potent than what we have now, because they have to use the strains that the FDA has or that they're allowed to use, and those strains are basically from 30 years ago. And obviously, you know, with plant, how we develop these plants, they're much more potent now. So when you look at the different receptors, you have CB1, which has that psychotropic effect, like on medical marijuana, and it does have some analgesic properties there. And then CB2 is the one for inflammation and nerve pain. And the THC component, usually the peak effect is 2 to 30 minutes, and it declines pretty quickly after that, and that's usually the inhaled. And orally, the bioavailability is low, meaning that the same dose isn't as effective as it would have been in another route. But it peaks a lot later, so 1 to 6 hours, and then half-life is 20 to 30 hours. But the THC component is the psychoactive component, and that's what we're concerned about. It can increase any type of any psychosis also. There is no standardized dosing. It is variable based on each individual person, based on genetics and metabolism and their past experience. So we do have one medication that is it's called dronabinol, and it's the similar compound, but really, you know, if you've smoked, you know, marijuana in the past, dronabinol just isn't as effective. So sometimes the CBD oils are stronger than what that dronabinol is. And then there really is no conversion from smoke to oral, and then we just titrate really slowly. Basically, a lot of the studies, again, no really good studies. Some studies show no therapeutic benefit. And again, is that because the dose, you know, the actual quantity was too low on that one? We've looked at HIV neuropathy. So there's all sorts of different options that we have when it comes to research, but there's not a whole lot that says, yes, this is safe. So the concerns really are, it's really costly if you do it the medical way. And in my state, in Minnesota right now, it is really expensive. It's about $100 to $300 per month. The legal issues, federal versus state, not taking it on planes, blah, blah, blah. Are we really exchanging one epidemic for another? And I think that's what we need to be aware of. Are we treating something, or are we just masking it again? And there are some studies that say this is more treating than opioids. So we actually kind of like medical marijuana better than we do opioids. But then again, what are the long-term effects? What's going to happen if we have, you know, all of these people on it for long periods of time, and I have 1 million people to look at? A lot of drug-drug interactions, it can be immunosuppressive. And so that doesn't necessarily mean it's going to be immunosuppressive in a good way for us. It could be in a bad way and not, you know, increasing our risk of infections. Side effects, cognitive decline, we have seen that. Psychosis, increased heart rate, nausea, vomiting, which is actually really interesting. You can have hyperemesis from too much of the THC component, and dry mouth. And I think those are the ones that I think are most important for us when we look at medical cannabis. So other topical agents, BioFreeze is one of them. You can use that up to 6 times a day, and it includes quite a bit of menthol. It is a counter irritant, so basically your brain can only think of one pain at a time. So a lot of my patients do find that really helpful. Capsaicin cream is another, which is cayenne pepper for some people for nerve pain. It basically depletes the substance P that is in there, which basically means that's irritating to your skin. And the problem is the capsaicin can be irritating as well. For the patients who tolerate it, some people find it really, really helpful. Others don't, so sometimes I have them mix it in an unscented lotion to help decrease the burn that's associated with it. But it is one of those options that we have that has less systemic side effects. And then we do have essential oils as well. And we look at Deep Blue as one of those that's made by doTERRA, and by no means do I have any affiliation with doTERRA at this point. But we can use essential oils orally as well if they're therapeutic grade. And we'll look at that a little bit more when it comes to essential oils. Low-dose naltrexone is one of those drugs that we've looked at in detail when it comes to pain and reducing inflammatory response. So we do see some good effect with fibromyalgia and Crohn's, multiple sclerosis, and complex regional pain syndrome. And so naltrexone comes as a tablet, which is 50 milligrams. That naltrexone tablet has been used for like alcohol abuse or opioid abuse, meaning it works opposite of an opioid. So it's going to compete for that opioid receptor. So if somebody's using high doses of heroin, then this is going to block some of that. But if you use it in really low doses, we found that if we gave morphine to rats in really low doses, the morphine caused pain. So they thought if they used an antagonist, so works the opposite way, could we treat pain? And this drug has been around for a good 30 years, and we use it primarily in palliative care. But we're using it a lot now more, again, benefit of the opioid epidemic. We're using it more now and actually finding good benefit. I've had a number of my patients completely get off all of their opioid pain medications using low-dose naltrexone because of the anti-inflammatory properties. Basically, neurons, some of the adaptation that occurs, you have a nerve here and a nerve here, and the microglial cells are in between. And initially, we thought these microglial cells didn't do anything, which is kind of what medicine says if we don't know. And now we're doing more research on those microglial cells, and those microglial cells actually produce inflammatory markers all by themselves. So I can solve all of the pain in somebody's body, and they're still going to feel pain because of those microglial cells. So this medication basically resets microglial cells. So you're going to have a little bit of increased pain when you start it, meaning you're going to have more inflammation because those cells are releasing it so that your body can clear it. Some of the other side effects that we see, I have seen some insomnia associated with that, which is rare but possible. And then I've also seen some increased depression, which is, again, possible. But usually it's a lower dose. We start really low, so I say 1 milligram as a starting dose and go up slowly by 1 milligram. And it's only once a day dosing, usually at bedtime. And it can be administered with opioid pain medications, just kept at least 2 hours apart. It is in also Contrae, which I think is a new medication coming out, or that just came out, that has an antidepressant with it as well. So another important thing is vitamin D. Low vitamin D can cause joint pain, muscle pain, fatigue, insomnia, headaches. So it's important to determine what your current dose is, get a vitamin D level, and then see if you're low. Low usually means there's inflammatory process as well. And so the question is there supplementation? Is that appropriate for you? And there was a lot of research that said supplementation, getting you between the dose or the level of 40 to 80 was recommended. I actually recommend more like 40 to 60, but most providers say that 20 is okay. So I try and get you somewhere in the middle there with supplementation, or better yet, go outside for 15 minutes 3 times a week, because you're going to get 8 forms of vitamin D there, whereas you only get 1 source of vitamin D from the tablet. And then the other concern that we have is we're testing active level, or we're testing storage levels of vitamin D. Well, your body has an active form as well, and we don't normally test that. So usually going with a more natural approach decreases all of those concerns. So Fibromyalgia Guidelines, really non-pharmacologic is the first active thing that we do. So are you getting exercise? Are you doing some type of mindfulness or decreasing the psychological effects? Are you doing acupuncture? Are you doing myofascial release? Are you getting enough sleep? How's your mood doing? Those are all really important. And then the drugs that are most recommended are duloxetine or Savella or milnacipran, or amitriptyline and cyclobenzaprine are other options that are possible. Gabapentin or Lyrica, like we talked about. And then opioids are not preferred, and it often makes it worse. So the studies that we found, the fibromyalgia gets worse with opioids. And again, avoiding the things that are quick answers for sleep, so the hypnotics or benzodiazepines. And then for myofascial pain, so the pain like trigger points or knots in your tissues or bands that you rub because it feels better that way, usually working it out, getting a massage or using some of the myofascial tools that we'll talk about in a minute. Or NSAID medications, so those anti-inflammatories that we talked about, like the ibuprofen or the Celebrex. There's a diclofenac patch as well, or the cream, the lidocaine cream, tizanidine, those muscle relaxants. Again, the duloxetine always comes up in every pain conversation because of the norepinephrine activity. The question whether tramadol is effective or not, some studies say yes, some studies say no. But really, manual therapy is the way to go, so getting somebody to work that out manually with their hands. So the Theracane, I do have a sample of this at one of the booths in the hall, but basically the Theracane is a hook-like handle that you can use to put it along whatever area is painful or not, and you use the other two handles to adjust that. To find what's comfortable and try and work that knot out. And then there's also a jackknobber, which is at the table as well. I have no financial agreements with any of these. I just know that they work for my patients as well as myself. So geriatric pain, of course, there's always concerns there, but we look at Tylenol as the first option for pain control, an anti-inflammatory if the risks do not exceed, or if the risks don't exceed the benefits on that one. And then opioid pain medications and gabapentin are usually our go-tos for that one, unfortunately, because we do have to avoid the cyclobenzaprine, anything that causes sedation, because they're on the Beers list, which is to be avoided. And again, if we try a therapeutic trial and they're at a therapeutic dose and you're not doing well, maybe that's not the right drug for you, and we discontinue. So if you have renal dysfunction, there is recommendations to avoid duloxetine. I have seen it used, but in really low doses, but there is a lot of monitoring that goes on with that. But the medications that are recommended are the Tylenol, the antidepressants, the tricyclics like the amitriptyline or the nortriptyline, and then the Savella or the milnacipran or Nucenta, just based on the way that they work. And then liver's dysfunction, there is question about Tylenol with that. If you have stable disease, there's usually no accumulation. You just stay at a lower dose and use it less frequently. Avoid NSAIDs with liver dysfunction. And then we do usually go for like gabapentin or Lyrica, as well as the tricyclic antidepressants, but avoiding carbamazepine. And then with pregnancy, we're always going to have Tylenol as the fallback because it is one of the safer drugs. You can use anti-inflammatories the first couple of trimesters as long as you speak to your provider and that they're aware and that there's no other associated risks with it. And I do not recommend low-dose naltrexone, although some people do. There's not enough studies out there to prove to me that there's no harm to a child. And then interventions, other interventions. So when you go to a pain clinic, there's epidural blocks, there's radiofrequency ablations, and these are all things that they can do with steroid injections. There's 1.5 million things that they can do. If you have one spot that hurts, it's easier to treat that one spot than to treat the whole body. So it could be beneficial to get assessed at a pain clinic to determine if these are appropriate for you. But also, I do recommend getting a second opinion as well, because everybody has one. So at least 2 different providers, it's good to see 2 different opinions. So medication considerations that I think are important. Sometimes we just have to start over, unfortunately. If I get a patient, and literally all of my patients have literally tried everything, and sometimes we just have to start over. Sometimes people start at gabapentin 300 milligrams, and I'm sorry, that's tough to tolerate sometimes. And so they just started too high. So would they have that same effect at 100? Sometimes that's what we have to figure out. Starting at, they start doses too high, they do it too quickly, we have to titrate very slowly as we go and only change one medication at a time. I have doctors who, basically, here, try these 3. Well, now I don't know what worked. What happened? And I don't want to be on all 3 forever. I don't know about you guys, but, I don't like taking that many. And I know you guys don't either. And, use the side effects to our benefit as far as if it causes sedation, let's use it for bedtime and see if we can get better sleep that way. And as the medications peak, talk to your pharmacist as far as when do these medications peak. Some of them peak in an hour or 2, depending on how they work. Pharmacogenetic testing, things that we talked about. So these are the list of drugs that I think are important. You can either have a genetic metabolism error that you can clear it too quickly or you can clear it too slowly. So if you're one of those patients that has a lot of drug-drug interactions or insensitivity to meds, you might want to consider getting genetic testing done to see if you have any of these genetic issues. Allergies to medications, we touched on this briefly. The real concerns, hives and facial swelling and anaphylaxis. Those are ones that are no-nos for me. Every other allergy after that can be an intolerance, and they're not really allergies. So really, was that a side effect because the dose was too high? So there's a lot of concerns to look at there. So complementary treatment that I think is really important, and we talk about this at the booth for some of these, essential oils being one of those, nutrition, looking at our nutrition, is it an anti-inflammatory diet? There's a lot of energy-based healing techniques as well as manipulative and body-based care. So that's chiropractor and myofascial work. Fascial distortion model is a new one that's out there that helps treat the pain. And then cognitive behavioral therapy, biofeedback, yoga, and exercise are all very important. So there's a lot of research when it comes to essential oils, and thank you to Mary for these wonderful slides. We're finding that there are anti-inflammatory properties, like with frankincense, and that ginger helps inhibit prostaglandin synthesis, so that's that inflammatory process. Lavender works on some of the same channels that the anti-seizure medications do that we use for mood. The other things, so we talked about psychology very briefly, biofeedback and mindfulness. There are a lot of apps available. You don't necessarily need to go to a psychologist first. Look at the various apps that are available. Insight is one of them. Calm is another app that are very helpful. Have that pain conversation with your doctor. Describe your pain. Document it appropriately. So what is your pain? What does it feel like? When does it happen? How did it start? They're not going to go home with you. So the more information you can provide to them, the more they can figure out what the cause of your pain is, even if they don't touch you. Ask for recommendations as far as think of all 4 wheels. How are we going to fill up all 4 wheels, and what other options do we have? Talk about your concerns and your worries. Develop a backup plan. If I'm in more pain, what am I going to do? What are those tools in your toolbox? What are you going to pull out at that time so that you're prepared when more pain happens? And then ask all of those questions. How does this medication work? What are the side effects? What are the long-term effects? Don't be scared to talk about all of that because it is all very important. Start a pain journal, absolutely vital. Monitor what your pain levels are. When is it worse? What makes it better? Express yourself clearly and directly, and be assertive and listen to what they have to say to make it a win-win situation. Take someone with you to your appointments, and then take responsibility to reach the goals that are set. So set those goals with your providers and take that responsibility to do that. These are some other tools that you have. Bullet journaling helps decrease anxiety. But really the goal is developing different tools, creating a support group, or finding those people that you can talk to. And here's the pain toolkit. There's the website there, very helpful. These are all the tools that you will need for pain management, and these are all tools that you do. So again, increased activity is the goal of the treatment, improving your quality of life. And then in summary, because I know I go long, pain is complex. Let's think outside of the box. Everyone is completely different and responds in different ways. Treat the pain at the source. Don't just mask the pain. I showed you many, many, many options available for pain control to let you guys know that it's not just opioids. And address all 4 tires, master each tool, figure out the tools that you want, how to use them, when to use them, keep your diary, and communicate effectively. Here's all of the resources for you guys. All the websites are in your handout. And then here is the very long list of references.